I want to introduce Dr. Richard Silverstein from Maryland. He has received an education from Syracuse University, where he graduated with a Bachelor of Science degree in biology. He continued his education at the William M. Scholl College of Podiatric Medicine in Chicago, Illinois, and completed his surgical residency training at Sinai Hospital of Baltimore. Dr. Silverstein is the division head of the podiatry section, Department of Surgery at Hartford Memorial Hospital, and is board certified by the American Board of Foot and Ankle Surgery. He also has had his work published and frequently lectures at various hospitals and local community organizations. So I want to thank Dr. Silverstein for being here today. This is sponsored by Magne-Tec, and I will let you go from here.
Thanks, Jana. My sound is okay?
Yes.
Okay, thanks. I wanted to thank everyone, thank the Ontario Society of Chiropodists for having me. I wish I could come up and visit. That's what the intent was earlier in the year. But again, I'm happy to be here and be able to share my thoughts on the topic of low-level laser therapy. Arconia is a company that I've been consulting for 4 years. I've been doing regenerative medicine for 5 years now, and have gotten great results in my own office. And that's what today's lecture is all about, talking about Arconia's laser options for plantar fasciitis. They also have the Lunula Laser for onychomycosis, and then also to spend a few minutes talking about the current climate in Canada in terms of Health Canada's edicts that came out last year, as well as their follow-up, because I have some opinions about that. Should put some fears to rest moving forward with these great treatment modalities. So why don't we get started? We have a lot of slides to go through. I do have an hour, and there is time for questions, so you can type them in and John will read them at the end, and we'll leave some time. Again, I've been practicing for 20 years now, hard to believe. I practice in Maryland. I put my email address down. This conversation today is hopefully going to spark some ideas in some of you. Others won't be interested, and that's okay. For those that are interested in moving forward with laser therapy, this is just a stepping stone or a beginning step in the process. You'll have more questions. I can't get through all the information today. There's a lot of research and evidence that supports the use of these lasers. So you can go to my website and see how I market it, unionfootcare.com, or you can call me on my cell. I don't mind. I'll return your call, or you can email me directly any questions you have. I can provide consent forms, whatever you need to make it a turnkey process. My financial disclosures are with Arconia Corporation, as well as Podiatry Content Connection. A shout out to Magne-Tec and Serge Amar for getting me up to speed on what Health Canada has been talking about in terms of their edicts back in last year, which we'll go over, and then their follow-up. But he was integral in kind of bringing me up to speed. I haven't been well versed with what's going on in the Canada side of laser therapy, but I am well versed in America. So before we get started, I'm going to start by asking 2 questions before we get on with the slides. And by a show of hands, I mean, you can see when this presentation was put together, it's when we could all convene in the same room. So on this day, 6 months since they started with COVID, I'm thankful that I have my health, and I hope everyone up there is doing well in Canada. But the perseverance of moving through Zoom calls to be able to kind of share our ideas and still be able to do our continuing education is paramount, because we have to move forward with society and what we need to do. So how many doctors discuss custom molded orthotics with their patients only to learn that they don't have a benefit, and they go on to sell them to them anyway for whatever you charge? This is just a quick couple questions, just kind of gear your thinking, and I'll explain that in a minute. And how many doctors in the room will do a PNA or an ingrown toenail procedure on a patient who has no insurance, and then you're going to charge them your set fee and then collect it? Most of the people in the room, if there was a room, would probably be raising their hands right now saying that they do both of these. I'm trying to get you into the frame of mind of having this conversation with your patients, that some services are not covered. It doesn't mean they don't work. Insurance doesn't cover everything. And I just want to convince you that you're already having this conversation with your patients, whether it's an infected ingrown nail that has to be managed, or someone who needs custom orthotics for painful plantar fasciitis. We are already having the discussion of non-covered services. We just need to kind of shift and think about how we can approach patients to talk about laser therapy for nail fungus or heel pain or Achilles tendon pain. So cold laser therapy, it's also known as low-level laser therapy, or LLLT. It's a form of medicine that uses low-level lasers or light-emitting diodes. Other names in the literature are low-power laser, soft laser, cold laser, biostimulation laser, therapeutic laser, and laser acupuncture. So you'll see all the different kinds of names out in the research world. They range on the electromagnetic spectrum from 6 to 980 nanometers. So what is a laser anyway? At its heart, it's an amplifier of electromagnetic energy in the form of a concentrated light beam. And it's based on a lot of the early work by Einstein. When we compare normal light versus laser light, on the left, you can see an incandescent light bulb that has a emitting laser or light energy in the form of many wavelengths and in a divergent manner. This differs in laser energy, which is monochromatic or one wavelength, in a coherent manner, which is parallel. And you can see that on the right. Laser classification system set up by ANSI, the American National Standards Institute in America, was set up initially just to help doctors and patients in protecting them when using a laser. It helps protect the skin and eyes and varies from class 1 through class 4 lasers. The higher up on the scale you are, the more heat is built up, more protections have to be afforded to the eyes as well as the skin. The two laser systems that we'll be discussing today, the FX635 as well as the Lunula Laser, are both operating at class 2 lasers, and they are not thermal, so there's no heat built up or pain to be felt. But because of that, we want to give lasers its due respect, and we do recommend wearing of protective eyeglasses. We want to have confidence in the science. Anytime I incorporate a new treatment modality in my office, I want to make sure that it's safe and it actually works. When I walk the halls of an exhibit, hopefully to do that pretty soon, sometime when COVID ends, I look for the next type of treatment option that I want to kind of incorporate, or new cutting edge science. And when reps from these companies come to my office, my first question is, well, what science has been done? Because if none has been done, I don't want to use my patients as guinea pigs, whether it's covered or not under insurance. My reputation is paramount, and that's what I'm trying to protect. So in the US, we have something called 510K pre-market notification. It's when a company will have a device, they'll apply to the FDA, and they'll send in the application for what it is. The FDA then takes the next 90 days to classify that device to see if they agree that it should proceed to commercialization, and if it's deemed safe and effective. And if it is, they give a 510K pre-market clearance, and they can proceed to market. This 510K approval is what we, or clearance is what we seek when we're talking about lasers. Lasers are not approved. Medications have approvals in the US. Lasers have clearance. So both of these lasers are 510K cleared for the use with plantar fasciitis in the case of the FX635, or onychomycosis in the case of the Lunula. So over 2,000 articles and research papers have been published to help support the idea of low-level laser therapy. It's going to be obvious after this lecture how we can kind of initiate the responses that we want, whether it's accelerating cell growth and tissue repair, accelerating collagen production with faster wound healing. So there's a role with diabetic wounds. But ultimately, these lasers are going to help reduce inflammation, reduce scar tissue formation. So they do have a place post-operatively for thick scar producers or keloid formers. Also helps reduce pain and acts as an analgesic, which is the overall intent of what we're trying to do. The other benefits of laser therapy would be inducing angiogenesis, which I'll show you upcoming, a slide on a ultrasound showing enhanced hyperemic effect, as well as inducing neurogenesis in our patients with painful diabetic neuropathy, which we can actually help reverse. It also is going to stimulate intracellular energy, or ATP, through a cascade that we'll get to in a moment. A little bit about Arconia, which brings us these novel lasers. Arconia was founded in 1996 as a small family business that's grown into an international enterprise. Their commitment to the advancement of low-level laser therapy through clinical and scientific research has transformed Arconia into a world leader in the field. As a manufacturer, they maintain their quality production standards by operating on 85% self-reliance. They're involved with every facet of their product's design, creation, clinical testing, assembly, and marketing, which is all maintained in-house. As marketers, they hold on to the highest customer service standards possible providing multimedia training and meeting all their clients' requests with creativity and a purpose. By overseeing the development of these specialized lasers, they have cultivated a unique market niche and are determined to maintain their status as industry leaders in the field of low-level laser therapy. Currently, Arconia is trying to achieve mycologic cure status with the Lunula Laser, which we'll get into in a few minutes. And I've been participating in their trials in my office, and we're doing cultures pre and post-treatment and yielding outstanding results. So what can we do with low-level laser therapy? Here in the center of the screen, you can see a laser emitter that is actually held about 4 inches from the surface of the skin in a parallel fashion. If we rotate clockwise, you see that it starts to decrease inflammation of the skin. It enhances nerve regeneration, increases cartilage production, enhances bone formation, decreases muscle atrophy, and increases muscle regeneration. It's also shown to increase collagen production, again, a factor with wound care, as well as that angiogenic effect, which we'll get into as well. So low-level laser therapy, again, in the lower extremity, which is appropriate for both of our professions. What conditions can we treat? It's not just plantar fasciitis, although plantar fasciitis is the key indication for the FX635. We have a whole host of acute conditions like Achilles tendonitis, plantar fasciitis, peroneal tendonitis, plantar capsulitis. We have a whole host of degenerative processes like osteoarthritis, complex regional pain syndrome. We have a bunch of neuropathic or neuropathy type conditions, whether it's Morton's neuroma, neuritis, entrapment neuropathy, or diabetic peripheral neuropathy. I have here, we also discussed wound healing and fracture healing, but eradicating dermatophyte infections is highlighted in orange because we really don't think of lasers having an antifungal effect, but they do, and we can discuss in a few minutes how we can make it beneficial for you to treat those conditions. The biological effects of coherent laser radiation on cells is termed photobiomodulation. And this is the mechanism of action we're speaking of. All light is radiant energy measured in discrete units or as photons, and its effects on cellular elements is mediated by photoacceptor molecules located throughout the human body. Two of which have been identified are cytochrome C oxidase, found in the electron transport chain of mitochondria, or porphyrins found in the plasma membrane of cells. Photoactivation of these two cellular elements leads to a signal cascade, which ultimately results into increased intracellular energy, or ATP, altered membrane permeability, and altered gene expression through the modulation of DNA transcription. Although the exact mechanism of this dynamic is unknown, these all lead to measurable physiologic changes, which results in our ability to see that they have decreased swelling, decreased pain, and it's not a transient effect because long after we stop laser therapy, the pain and inflammation does not return. So how do we treat these conditions prior to laser therapy? If you're thinking about incorporating them, they're not necessarily a first-line defense. I would say if you're looking to treat nail fungus, yes, you can go to the Lunula first. But when we're treating musculoskeletal issues with the FX635, we're going to educate the patient after we diagnose them. We're going to possibly dispense durable medical goods, whether it's custom orthotics or doing low-dye strapping. We're going to recommend stretches and exercises. We're going to limit high-impact activities like Zumba classes. And we're going to recommend maybe modifications at work. If they stand on concrete all day, we may want to put them on a foam mat. We're going to encourage disease management if they have diabetes and they're uncontrolled sugar. Prescribing NSAIDs and giving steroid injections are falling out of favor due to the side effects and the short-term relief that's obtained with the injections, or when you stop NSAIDs, the pain can typically return. After those conservative management modalities have been attempted, you can recommend laser therapy. And if that fails, you can go into surgical management. This is simply another way that we have to treat our patients prior to recommending surgical intervention. So here's the Arconia FX635. It's a quick and simple non-invasive laser procedure that utilizes low-level laser therapy operating at the 635 nanometer. And again, class 2 non-thermal. You don't have to worry about burning your diabetics or neuropathic patients. It's fully automated, unattended treatment delivery system. It fully reproduces the same treatment each time. You don't have to shine a wand. However, there are handheld units like the PL Touch that are have a single laser. This has 3 laser beams, and it's 3 distinct laser heads that allow for optimal treatment coverage. The gantry has multiple joints allowing for proper adjusting and positioning of the patient prior to rendering treatment. Here's a picture of their 510K clearance letter, which can be found the Department of Health and Human Services website. Their achievement was on April 14th, 2014. The Arconia laser was clearly indicated as an adjunct treatment to help reduce the symptoms of plantar fasciitis. What you're looking at is the only laser on the market that has 510K clearance in the US for plantar fasciitis. I use that to my advantage when advertising it because those words are very powerful. You can see that the touchpad control has a keypad, which can help lock the laser so no one is using it when you're not in the office. The software loads quickly. You can have predetermined set positions based on, or times based on the pathology that you're treating, and it loads quickly and starts quickly. So what's the normal treatment protocol for plantar fasciitis? I do it twice a week, 10 minutes per foot, not on back-to-back days, for 3 weeks for an average of 6 total treatments. I will gauge their success filling out an analog pain scale, which I'll get to in a minute. And if we have to increase the number of treatments, I do so. I really kind of charge them a package. I give them a certain amount. And then if we have to go above it, I don't charge them again because they've obviously committed from day one. And I just keep lasering them until we max out on the benefit. If on the analog pain scale, they're continuing to show improvement, I'm not going to stop because they've run out of treatments. We're just going to charge an appropriate amount in the beginning to cover our expenses, and we will continue lasering until they kind of plateau. So the other key point is that you have to continue all conservative therapy. This is not a magic bullet that replaces stretches and weight bearing with proper shoes and orthotics. This is an augmenting type treatment that helps get them to where they need to go quicker, and it actually doesn't mask the inflammation, it actually heals up the condition. This is the analog pain scale that I'd be happy to share with you. We fill it out each time, actually have the patient fill it out. It's also important for them to see where they've been prior so they can kind of accurately reflect and compare today versus last week. This was the patient that I had starting day 1, 9.5 and 10 on both feet through the 2nd, 3rd, and 4th treatments. Again, that's roughly about 2 weeks. And then 5th, 6th, 7th, and 8th, kind of moving down that pain scale. And after 11 treatments down at that 1.5, 2 level, they were high impact on their feet, standing many hours a day. I say if you have pain at the end of the day, that's normal. If you go to sleep and then wake up pain-free, that's exactly what we want. But when they wake up with pain from the night before, that's still some benefit to be obtained. But a normal amount of pain after standing 8 hours is going to be normal. Peripheral neuropathy in the FX635. Why are we going to talk about neuropathy? We see a ton of it in our office. When you compare large fiber versus small fiber, most of the neuropathy we see is a small fiber neuropathy associated with diabetes mellitus. There are many other reasons. Patients can present to the office with these painful conditions, metabolic syndrome, idiopathic or familial. Alcohol abusers can come in with painful neuropathy due to the effects of alcohol. HIV, as well as chemotherapeutic agents, can leave patients with neuropathy. Most of the ones that we want to treat with the FX635 present with a stocking and glove distribution. Early on, neuropathy shows hyperesthesia and pain. Late, however, they have hyposthesia and numbness. Numbness is never going to kind of keep somebody up at night or cause them to have a lack of sleep. But the first gentleman I ever treated for diabetic peripheral neuropathy with the FX, he came in and he looked haggard, and I said, "What's the matter?" He said, "I haven't been able to sleep because my feet feel like they're on fire." He was a 72-year-old gentleman who had been diabetic for over 25 years, and for most of the first 15 years, he was an uncontrolled diabetic, developed neuropathy. Now his A1C was down under 7, stays controlled, but he's still left with this painful burning. So we treated him with the FX635, and for neuropathy, we'll treat them 3 times a week for 4 weeks. So they're coming in and committing to a session, 12 sessions in that month. And after a week and a half, his kind of paresthesias kind of dampened, and he was able to finally sleep at night, which allowed him to be able to exercise during the day. And if you can't sleep at night, you know what a tailspin that puts on your next day. And this was happening every night for him. What I will say is that you cannot use this with someone who has an A1C north of 7, because that continual damage to their nerve fibers is going to give you not a lasting effect of the FX. They may feel better after a couple weeks, but once they stop and they continue to assault those nerves with the high sugar levels, this will not be a long-term gain. That's why for that purpose, when their sugar is over 7, I use this as a tool to motivate them. Because if they're interested in doing laser, I say you need to get your sugar down so we can get rid of that pain once and for all. So for the gentleman that I had treated, he had been uncontrolled earlier in his life and developed neuropathy. And now that he was controlled, we could get rid of the painful paresthesias he was having by treating him 12 sessions. And then he was able to sleep at night and exercise. And I continue to see him and he's doing great. So how do we diagnose peripheral neuropathy? I don't know that I've ever done an epidermal nerve biopsy because most of my neuropathic patients have atrophic skin, very brittle with poor circulation. But just for completeness sake, I put it in the slideshow today or the presentation. There's an established normative range on the top of the foot and the lower leg for density of small fiber nerves. So you can do a punch biopsy on the top and the lower extremity as evidence in these 2 pictures. And you'll get a biopsy report back from the pathology lab, your favorite pathology lab, whichever it is. On the left, you're going to see a slide of the normal skin. On the right, you see small fiber neuropathy. What the right slide lacks is those purple squiggly lines, which are the small fibers, which kind of go from the dermis up to the into that reticular area. So here we have the values on the bottom where it says result value, right foot, right calf, left calf. And those values demonstrate lower density than what's normal. So abnormal would be under 3 in the foot and under 5 in the calf. So this would be the pathology report for someone with small fiber neuropathy. This is a 65-year-old gentleman with clinical symptoms of small fiber neuropathy, similar to the gentleman that I spoke to, but this wasn't his biopsy per se. So on the left, you see before laser, the right foot density has 1.16. After 12 sessions, after 4 weeks, we've actually regenerated nerves. This is that neurogenesis that we saw in the earlier slide as we rotated around using the laser. So after laser, his density got to 4.91, which was great. And this is what would correlate with a decrease in the paresthesias that the patient exhibits. I've never tried treating someone with true numbness that didn't have pain or burning to eliminate to see if we could create sensation from when they had no sensation, because those patients typically aren't complaining. At risk for ulcer, 100% yes, but they also aren't complaining of pain at night because they don't have any sensation at all. So I'm not aggressively treating them, but it could be a good study to do in the future. Here on the left foot, 1.33 density, and after 12 treatments, bumps up to 4.37, which is more in that normal range. Again, clinically associating with decreased symptoms. We're going to show a quick video here. I talked earlier about angiogenesis. This is a before and after low-level laser therapy ultrasound. Think of first, second, third, and fourth as the weeks. And before the first treatment, you can see on the upper left, decreased blood flow or a normal amount of blood flow. Post-treatment of that first treatment week, you see an enhanced hyperemic effect. The key here is that once you wait after week 1 and go on to week 2, you don't start week 2 where you were with week 1. So it kind of builds as a step. And then starting week 2, we can enhance after treatment hyperemic effect. And then week 3 starts, and that's week 3 starts with hyperemia since week 2 and week 1. This doesn't cause edema, but it's a hyperemic effect, which helps bring in more growth factors and proteins to the area to help stimulate the healing process. What we know is that hypoechoic plantar fascia, which can become thickened and with decreased blood supply, this helps nurture that plantar fascia and actually can help restore the normal thickness and take those symptoms away. So that's the increased vascularity that we see before and after treatment. And I would be more worried if at the beginning of the week you were starting basically where you were the prior week, but it's not. It's a stepping stone. You can see through each week you're increasing the amount of blood flow to that area. We're going to switch gears right now because we're about halfway done. Onychomycosis, the facts, obviously most common disease of the nail. We really shouldn't ever have to advertise for this condition because it's in our office every day. We need to stop ignoring it. We need to, doctors and primary cares and ERs, they need to take the patient's shoes and socks off. A lot of pathology is missed because of a cold treatment room, so they let them keep their socks on during their visits. But these are conditions that can be treated. They can lead to other infections like cutaneous fungal infections, which occur 30% of the time. In my office, we only treat nail fungus with laser once we've gotten the skin infection under control. It's the old, saying, is it the chicken or the egg? We don't know what caused what, but as long as they have a skin infection, it can seed infection into the nails. So if they're considering laser therapy for the toenails, I will absolutely prescribe a topical on day 1 while we're waiting on biopsy of the nail results to get the skin infection under control. Once that is eradicated, we can move on to treating the toenails. Factors that are going to cause patients to seek treatment: vanity, men and women equal, 50 and 50 in my perspective. Pain, wearing a steel-toed boot or other kind of shoe, clog can cause pain when that thick nail rubs on the end, creating paronychia or just long-term pain, or the inability to work. All these factors have to be taken into account. This is an infection and we want to eradicate it. We don't need to advertise for this. It comes in our office every day and we see it all the time. The 3 main classes, actually just for review, the dermatophytes make up the bulk, T. rubrum of 90% for all fungal infections, yeast 8%, and non-dermatophyte molds round out with 2%. Diagnosis of onychomycosis. After 20 years, I would think I'd pretty much know which is and which is not. Have I been fooled? Of course. And the reason that we need to do a biopsy is there's many conditions that can mimic nail fungus, whether it's psoriatic arthritis, lichen planus, contact dermatitis, or how about traumatic injury to the nail bed? You get all that, you get that patient that comes in with all 10 toes are fungal, but one of them is so thick and distorted, it's growing off to the side, it's lysing from the nail bed. Invariably, I'll ask that patient, did you ever drop anything on that toe? And invariably the answer is yes. We need to explain this condition to the patient because although that nail in particular might likely have a fungus in it, the traumatic injury to that nail changes the way the nail grows regardless of the infection. So the important part to remind a patient is we're getting rid of the infection and fungus, number 1, because it is an infection that can seed to other areas. But number 2, we want to make sure that they understand that not every toenail may return to normal. That thickened, traumatic, injured nail, we can rid it of the fungus. It may still grow back lysing due to disappearing nail bed syndrome, or it may look a little discolored or funky, but it's just not going to look the way it was when they were born. And there's nothing we can do about that. And there's nothing wrong with explaining that, because what that does is it sets up the expectation that maybe 9 of my nails will look great, and that one is always going to look a little bit distorted. But again, after we use the laser, it's going to get rid of the infection component. Being honest with your patient is paramount because you have to set the expectation. In my office, we talk about their infection being a mild, moderate, or severe type of infection, and I'll classify it for them. They don't need to know if it's total dystrophic or proximal subungual, but patients typically who don't understand the terminology can understand mild, moderate, or severe, and that helps set the expectation on how they will do. The other treatment options for nail fungus and their cure rates, terbinafine, which is what we kind of write most of the time, has a mycological cure rate of 58%. Obviously, taking medication for 90 days can cause side effects. Patients need to understand that. Jublia, which we've been inundated with press releases and commercials, very expensive medication, surprisingly only has between a 15 and 18% complete cure rate. Complete cure rate means mycological cure plus complete restoration of that nail to without any impairment seen. So that to me is a very low percentage. What we're seeing in our office with the Lunula Laser is upwards of 70 to 80% in terms of mycological cure, as well as complete restoration of the nail without any impairment. And again, minus the nails that are traumatically injured, because we don't want to set that expectation wrong for the patient. Side effects, that's going to kind of sometimes drive patients away from medications. We have patients that are just not pill people, and they want to do everything but. So it can cause issues with the liver, taste disturbance, smell disturbance, which kind of parallels COVID, depression symptoms, as well as hematologic effects, skin hypersensitivity reactions. Some people just don't want any parts of this, and they'll jump right to laser. But it is important to biopsy every nail. Not all 10 within a patient, but at least go for the most fungal nail. So you have a biopsy report that has a pathologist reading it saying there is fungus. This is just another level of protection, which helps support our diagnosis. If they have psoriatic arthritis, we don't want to necessarily treat them for nail fungus if we haven't proven that there's a fungus, because a laser will do absolutely nothing for a psoriatic nail. Your patient would be very upset if they find out they have psoriasis or psoriatic nails and your laser didn't work after they paid a lot of money out of pocket. So the answer to all these other treatments, which have low mycological cure rates and long durations with possible side effects, is the Lunula Laser, again, brought to us by Arconia. It is a 510K cleared laser. Looks like a little toaster oven, weighs about 22 pounds, completely portable. Again, it has a keypad, which helps keep it limited to when the doctor wants to treat. You hide the key in your office or lock it up. The software, again, loads quickly, and the little door kind of slides down. We'll get to more of that in a minute. This is the 510K clearance letter, which shows that it's approved in the United States, the Lunula Laser it is, for the temporary clearance of nails caused by nail fungus or onychomycosis. There are two wavelengths in here. The FX635 had one wavelength. It was the 635. They've incorporated the 635 as well as the 405 wavelength in here. What you can see right there is a foot in the right foot inside the laser. They sit in a recumbent position, and the laser, they will wear goggles even though the laser shines down. There's two lasers that are rotating. This is with a proprietary line generating laser beam. It basically rotates a line in both directions and both wavelengths, the 405 and 635. The 635 is more of the red laser, the 405 being a purple laser. The antifungal effects, which is what we want with the mechanism of action, the 405 wavelength, which is more of the purple, has been shown to be antifungal, antibacterial, as well as antimicrobial. The 405 wavelength helps stimulate reactive oxygen species within the body's cells. This reactive oxygen species helps produce an enzyme called superoxide dismutase. Superoxide dismutase is the enzyme that helps cause lipid peroxidation. Lipid peroxidation helps degrade the phospholipid layer of the fungal cell membrane and ultimately causes lysis of the fungal cell. This is not targeting normal cells, it only targets fungal cells. That's why the medications can have such side effects, because they don't target just fungal cells. They can target the inside of your GI system, it can target white blood cells, and that's why there's so many side effects. With this laser, again, non-thermal, you don't have to worry about burning a neuropathic patient or someone with poor circulation. In fact, the 635 wavelength helps bring in blood flow, bring in neutrophils and macrophages to help fight this infection. So our patients that are typically straught with nail fungus are the older and elderly patients that have diminished circulation. So that's why they've used the 635 wavelength, because this photomodulation aspect of the 635 wavelength helps the immunological response by the patient to help fight this infection. So treatment regimen for onychomycosis. In my office, we're treating the patient once a week and it's 12-minute session for each foot. If they only had 3 fungal nails on the right foot, I treat both feet, because typically there are some studies that show that early signs of infection may not show any changes in the nail. I want to be complete with the patient. You know, when you sleep with your feet next to each other or you shower, there is the possibility of transmitting from one foot to the other. And for completeness sake, I want to make sure we're treating all 10 toes. So we're going to do that for once a week, 12 minutes per foot. So in 24 minutes, you've treated them. It's automated, non-touch, non-thermal, and we'll have them come back after 6 weeks. 6 weeks after that fourth treatment is about 10 weeks since the first treatment, and we should begin to see the beginning signs of a nail that's clearing. We do heavily debride the nail initially. The reason for that, although it's not recommended, not that it's not recommended, it's not required under the FDA clearance. My opinion is get rid of as much fungus as you can initially, and you have less to eradicate, less thickness to the nail for the laser to penetrate, and they're going to do much better. So by after the time of day 1 where I'm debriding, I will debride the nail again after the third treatment, because nails typically aren't going to grow that much in a week. But the patient always feels more comfortable because that thick nail is now ground down and it looks much healthier and normal, even though we're still treating the infection. This is the other key point here, is that a treatment for nail fungus is getting rid of it right now. But that doesn't mean they can't ever get it again. If the patient got this because they wore a wet work boot, then it's my job as the doctor to identify that and say, hey, you need to buy a couple pair, 2 or 3 pairs of boots, and wear them every other day. And when you're done with them in a day, put your hand in there. If it's wet, undo the laces, pull out the tongue, keep them in a well-ventilated area, spray with antifungals, put powder on your feet, put powder on your socks, put powder on your shoes, change your socks more than once a day if your feet sweat a lot. Make sure you bleach out your shower, your bathtub. This is an ongoing process. If they don't understand this and make the changes, then the reasons that brought them in with this in the first time will undoubtedly cause them to get this again, and they're not going to be happy when they need to be treated again, and you go to charge them again because they haven't followed the instructions. I've had a couple people come back after a year or two and it came back. I'll say, well, did you sterilize your shoes? We give out an ultraviolet shoe sterilizer, and they'll say no, and I didn't put powder in my shoes and my feet sweat a lot. And then it defrays the responsibility back to them. We can only do so much because this treatment is not a cure forever. We continually need to help prevent it from happening. So here you see before and after pics. This on the left, top left looks like total dystrophic. The top right looks like it's kind of growing out there after 6 months. On the left, you see looks like distal subungual, and then on the right, kind of complete clearance. These pictures look a little green. They look a little green on my screen. But again, pictures are, we have a ton of pictures of patients that have actually done really well. And you got to kind of look through them and see them and decide for yourself. But this to me was a game changer for my practice because my patients love the fact that this is regenerative and these things aren't going to harm their body. So the FDA timeline, there's a lot of research that I don't have the time to give you, but there are pilot studies and research articles demonstrating for plantar fasciitis for the FX, as well as the Lunula for nail fungus. Just request this through Magne-Tec or Serge Amar, because he can get you in touch with these articles through me. I can also give you the consent forms and whatever you would need. Feel free to stop by to talk to him. So the FDA timeline from first submission to final approval was just about 6 years. This has been thoroughly researched with 1 pilot study and 3 level 1 IRB approved clinical trials conducted in the US and Europe. The study demonstrated 133% increase in clear nail growth. So if you look at baseline, if that patient had 4.6 millimeters of clear nail growth and the rest of their nail was fungus, after 6 months, that nail grew out, and they measure, because we do it in our office with this study, scientifically after taking pictures, 10.75 millimeters, which comes to 133% increase. This is a great slide. It compares Lunula with other thermal lasers. The fact that this is a non-thermal laser means you don't have to restrict the number of patients that you could potentially use this on. You don't have to worry that you're diabetic without sensation or your alcohol patient who consumes to excess and has neuropathy is going to be burned. They're never going to feel anything because there's no heat to be felt. My biggest thing is that I have to convince them that even though they don't feel anything, something is happening and something is working. But they do see that after several weeks and the nail starts to grow out. It says no required debridement of nails, and that is true, but my recommendation is debride the heck out of the nail from distal to proximal. As much fungus as you can get rid of allows a better job. The treatment spot size. This is not a typo, 28.62 centimeters squared. Again, that swath of the double laser that's rotating has a treatment area of 28.62 centimeters squared, which is more than enough space to be able to rotate around the whole forefoot. and a 2 to 10 millimeter spot size. It's covered up. I can't really read it. I think it was 2 to 10 on the other thermal lasers. That means that you kind of have to move that stylus around and heat up each area to a certain amount. It won't look any different before or after. And if you miss a spot, then you've left an island of fungus that can continue to thrive. And the treatment time, 12 minutes for all 5 toes, or 25 minutes for the total bilateral treatment of the patient, versus 4 to 5 minutes of manual time per nail. This is probably my favorite slide. It's a great area. It's a great representation of surface area discrepancy. On the left, you see the lunula. Any area that's purple is the area that's being treated by the laser. The proximal, medial, lateral nail fold, the subungual area, as well as the nail plate. On the right, you see these different 2 to 10 millimeter spot sizes. You have to move that stylus around, hold it there. You do need to heat it up to 104 to 106 degrees, which is very hot. And if you miss a spot, it won't look any different after treatment than before, and you'll never know if you missed anything. I set this, turned it on. It's touchless. There's no interaction with the patient other than having them put their foot in, turning it on, and I leave the room. We'll go through the video. Anybody notice in that video that the examples that they used were basically like superficial onychomycosis, which to me, you can kind of scrub it off with a Dremel. That's my biggest complaint. They didn't ask me about that video or put the ones that I had recommend, or not that I recommended, I would have put in. But from the slides prior, you can see that it does work on total dystrophic nails. This was a gentleman that came into my office June of 2018, and he was ready to have a PNA because he was younger, in his mid-40s, wanted to go to the beach with sandals, but was totally embarrassed by this nail. You can see he even came in with the beach on him. He had some sand on there. So you see that left hallux nail is totally dystrophic. It's also growing off at an angle, which to me means he had a prior traumatic injury. And when you look down the angle, or the distal angle of this toe, you can probably see back to the proximal nail fold because he has lysis of that nail plate. He also probably has disappearing nail bed syndrome from such chronic lysis of this nail. You can also see the second toe is infected. I told him, let's take this nail off temporarily, not use phenol, allow the procedure to heal up. Let's get rid of this old ugly nail and then treat with 4 times on the nail bed, and then treat all 10 toes, and then see where we're at. If we can get rid of this thick nail, we might be able to restore some of that nail and have it grow out. Maybe more proximal, it'll be attached, but distally it could grow off. He was willing to do this, as a PNA would have been a permanent procedure, and he would have dealt with the vanity associated with that, but obviously less than having to walk around with this very thick dystrophic nail. So after 6 months, this is what we had done. The initial procedure was basically a total nail avulsion, not using phenol. I hadn't done one in years because I usually do phenol, whether medial, lateral, or total, just to get rid of the nail. His second toe obviously looks a lot better as well. And you can see what's growing out here is tightly adhered down to that nail. You can see it's going to grow out another 2 or 3 millimeters, then probably start to kind of elevate. So I told him we can kind of keep it filed down. He was thrilled that he didn't have to get rid of his toenail and he could wear sandals. And this was only after 6 months. So we were going to continue to see him. I don't have the follow-up picture in here. But this is another reason why a non-thermal laser can be used on the nail bed without any toenail. Total indication is having a nail as dystrophic as it was. Do a procedure, remove the nail, let that heal up. I'll do a total nail avulsion, have them come back in 2 weeks. If it's all healed, we'll start laser treatment that day. This just gives you another idea and another treatment way to help another patient with their vanity issues, as opposed to just totally getting rid of the nail. Patients will love you for this. You're thinking outside the box. Dr. So-and-so down the street doesn't do this, doesn't think to do this. They're just in and out with the patients. This is where you really start to establish your reputation as a forward thinker. In terms of the Health Canada update, Serge Amar at Magne-Tec had told me about this, and I looked into it. On July 25th of last year, Health Canada issued a report saying that laser-based medical devices are not authorized to treat onychomycosis. Canadians are putting themselves, that statement is an opinion, okay? So they're saying we're just not going to cover it or have it authorized. The next statement, Canadians are putting themselves at risk to be treated in clinics, spas, or vendors versus seeking medical attention for medical treatment. I agree with that 100%. If you're not seeing a doctor in a clinic, a spa, or a vendor, then you're not doing what you need to figure out if this is or is not a fungus. You need to see a medical professional who can do a biopsy. Patients with diabetes or weakened immune systems may be at greater risk of developing serious complications, including bacterial skin infections and conditions that threaten the limbs. I agree with this one also. This is totally true and actually supports the second idea there. Then Health Canada updated in December 5th of 2019, probably from everyone clamoring and pushing back. And if you look at these two statements, while some, I'll read them both to you. One of them is from the US, one of them is from Canada. One of them is the Health Canada update from December 2019. While some laser-based medical devices are licensed to temporarily increase the clarity of the nail in patients with a nail infection, none have been licensed to cure these infections. I agree with that. We're not curing the patient. When you have bronchitis and you go to your doctor and they prescribe Augmentin and you take it and you come back 2 weeks later and you're breathing easy and you're talking normal, does your doctor say, wow, I've cured you of bronchitis, you will never get it again? No, we've actually treated the infection, got rid of it, but that antibiotic won't ever make you susceptible to getting it again. And that to me is the point here. The point is that we're not curing it forever, because if they go out and catch it again, technically we haven't cured them. And that's true. So what we're doing is, for the temporary clearance of the nail, we're curing them for until they get infected again, if they get infected again. This goes into the responsibility of the patient again. It shifts the conversation. It allows us to be able to say, Mrs. Smith, we're going to be able to treat you with this laser and we're going to get you better, but you have to do these things at home to help prevent the chance for reinfection. And if you do, then it's likely this will never come back. You just can't write on a label or give an indication which may not be true. And that's to the letter of what they're doing. They're saying this, and I agree with that. The other statement, whether it was the US or Canada, the Lunula Laser device is indicated for the use for temporary increase of clear nails in patients with onychomycosis. This statement is actually the clearance statement that is for the Lunula Laser, and it's written in the US. These two statements are basically saying the same thing: temporary increase of clear nail. Not because it's definitely going to come back, but if they meet the environment and fungus in the environment again, and they don't do what we say, the chance is that it can come back. I would not let these statements deter you or remove the motivation to help your patients with these lasers. In fact, I think they made it easier to direct these patients from spas and clinics and vendors right into your lap, into your office, because it's basically saying these are medical conditions and they need to be treated as such. And my caveat to you all is contact your local provincial regulatory body if you have questions regarding the use of these devices. So along with the lines of giving the patient the responsibility, they should be using a shoes app. I give this with every patient. I charge $1,075 for a patient to have either 4 to 6 laser treatments, and with that, I give them this for free. It's an ultraviolet shoe sterilizer. Once you purchase a Lunula Laser, you can get the cheapest rate on the shoes app in the country, because I negotiated it personally, because I knew when I bought the laser, I was going to be giving out a ton of these. I wanted to be able to give something to the people that are smart enough to buy the Lunula Laser, a perk. So I negotiated the cheapest rate on the shoes app. You buy about 10 to 12, you save about $5 to $6 per unit. Patients love it. And it also allows us to follow up with them. Are you shoe zapping your shoes? It doesn't have to be done every day, but if they're wearing shoes and having issues with smell or odor or perspiration, they need to be shoe zapping and keeping them clean and dry. The other thing I give them.
Dr. Silverstein, we have a few, we're coming up to the end of the session. We do have some questions. So
okay, sure.
Wrap it up and then we can do the questions. Okay,
I need about a minute. So we have this Lunula Laser, which is an information sheet, talks about the shoes app, what they can do at home. I have them buy Regimen AF spray just to help them as they move along, to keep fungus from getting on their feet. Once they sign the consent, this is the last sheet that they get to take home with them. It's everything that they can do at home. Return on investment, there's a lot of marketing here that I won't be able to get to, but I'll just whet your appetite by saying that you can have these brochures printed out by Arconia. Once you sign on with them, it's not the end, it's the beginning of the relationship. They simply will upload these PDF files to you, and then you can upload them to Vistaprint, where you can print out thousands of them, flood your office with them, flood your patients with them, put your website on them, all your information, so patients can start to understand what you're doing. Update your website. This is my website, which has laser treatment for nail fungus, as well as laser treatment for heel pain. Put these videos that are very easy to upload. They're free, and they're very simple and in layman's terms for your patients to understand. In terms of radio advertising, you can advertise you have the only laser cleared for plantar fasciitis in the USA, which is very resounding, and it kind of resonates with patients. I never wanted pressure of having to do a certain volume a month. Certain lasers had that caveat. With this laser, once you own it, you go at your own speed. You go at your own comfort level. I need to sleep at night. I want patients to understand that they're going to move forward with this when we're ready, when they're ready, and I'm not going to put pressure. And any questions anyone has, feel free to give me a call. Again, you can visit Magne-Tec. Serge Amar has been great in helping me get up to speed on the issues with Health Canada. I wouldn't have that as a deterrent. I think they're giving the green light for doctors to treat this condition with these proprietary lasers that have never demonstrated a bad side effect. So I just wanted to thank everybody, and we'll get to the questions.
Okay, thank you so much. So the first question is, in LLLT, what tissue depth is the therapeutic benefit limited to?
Well, that's a great question. This is a cascade that occurs. So although the tissue depth is not as deep as a class 4 laser, it works in several millimeters of depth. In the foot and ankle, I can basically use the laser on any area because it has a cascading effect. Once it occurs on the surface, it penetrates deep through the mechanism of action that we had discussed. So it's not always about how high and how powerful your laser is in terms of heat and how deep you can get with that laser, because obviously the treatment time has to go down when the heat is built up so high so the patient doesn't burn. But in terms of efficacy, it's not about the heat or the power, it's about outcome results. And that's why the amount of research that Arconia has done, both in the Lunula and the FX, it shows that although it may not penetrate as deep as the class 4 lasers, it's just as every efficacious, or even more so, in my opinion.
Great, thank you. Next question. How does this compare to the MLS laser?
MLS is a class 4 laser, as we're talking about it. I've never owned the MLS laser. I purchased my own lasers and then started consulting for Arconia. So I wasn't handed my lasers or said, hey, talk about this. I did this on my own. And then it got involved with their research. So you're talking about a class 4 versus class 2 laser. Class 4 MLS laser has an indication for musculoskeletal. I don't know of the research that's gone into it, but I don't think it has a plantar fascial indication on the actual clearance form. Yes, musculoskeletal means anything musculoskeletal in the body. I wanted to get behind a company that looked at foot and ankle pathology specifically, and that's where all their research was guided, and it was a no-brainer for me when I saw the results.
Okay, thank you. Next question. What do you recommend they spray their shoes with? Do you have a product that you prefer?
Any of the topical antifungals are fine. The important thing is to have and make sure that that spray has dried. Even as a wet antifungal spray, if it makes their socks wet and makes their feet wet, that wetness and moist atmosphere is a great environment for fungus to thrive. I have them spray their feet with Regimen AF spray, which is a alcohol, or they have a powder-based spray, and that actually dries very quickly. But as long as they're undoing their laces and pulling the tongue out, I see a ton of people with steel-toe boots. That toe cage in the forefoot protects their toes, but it also prevents ventilation. So that's why they are at more risk of developing these types of infection, due to the fact that their foot is not breathing in that shoe.
Okay, excellent. And next question is, how well does the Lunula laser work on very chronic, thick, and dystrophic onychomycotic nails?
Well, again, we have to discern, is this just onychomycosis or onychomycosis and traumatic injury on top of it? We know we can pick those out. They kind of grow off to the side or have lysis. Again, I set the parameter of mild, moderate, or severe. With my patients, if they have a mild or moderate case of nail fungus, I say they're going to get outstanding results and they'll be very happy. On those really, really thick nails, the ones that are very thick and dystrophic, if they had 10 of those, I would say we need to kind of wait and see. I would grind them down. They're going to get good results, but we also have to kind of temper the expectation just because of prior traumatic injury, which can cause that nail to be thick. regardless if there's an infection. So the important point to express to that type of patient is that the important thing is we're getting rid of the infection. How they look afterward, if that's what your goal is, we may not get them to look like 10 beautiful, normal new nails because you have such a severe infection. So classify it to the patient as mild, moderate, or severe, and then they're going to have a realistic expectation.
Okay, that's great. I don't think we have any other questions that have come in. I just wanted to ask, when you're finished with the Lunula, what is your post-op care with them? Do you have them bring fresh socks to wear or different shoes to wear home? Do you spray or treat their shoes while they're getting the treatment so they can wear them home?
The shoe zap is given to them initially, so they start shoe zapping. We start with chronic skin infection therapy prior to Lunula. Once the skin is cleared, once they have their shoe zap, they come to the first appointment. We treat them. They can go home in the same socks and same shoes. They also have that list of things that they can do at home, and we're kind of reinforcing that along the way. But there's no real post-op change that they have to immediately do after treatment one.
Oh, that's great. And no other questions have come in. So I'm going to thank you and thank Magne-Tec for sponsoring. Oh, wait, sorry. We did get some questions that just popped up right now.
Okay.
After a TNA with no phenol, it was mentioned that laser treatment starts after 2 weeks of procedure. Can you start earlier than 2 weeks?
Absolutely. Typically, if it's a really thick nail, it may be tightly adhered down to that nail bed. Others with a real thick nail may have a lot of lysis and may not be a big deal to pop the nail off. I do it for simplicity. I don't want to bring them back in a week, find it's still draining or oozing, and then have to have them come back another week. So I just say 2 weeks because most 95% of the people are done after 2 weeks and they can kind of begin therapy. But if you wanted to try it at a week, that would be fine. I just want to make sure that the skin is completely healed and dry. Sometimes having fluid on the surface can disperse the laser, and I don't want anything to affect the treatment. So I want to wait till that's completely healed and the patient's pain-free. Great question, though.
And this is the last one, and then we'll end the session, is does the FX635 have any other musculoskeletal indications?
Well, indication on the clearance is for plantar fasciitis. I've used it for diabetic peripheral neuropathy, Achilles tendonitis, plantar capsulopathy. I've also used it in concert for neuromas, as well as sinus tarsitis, ankle pain, ankle sprains, post-op, surgical swelling, some residual post-op swelling and pain after bunions, hammer toes, basically anything. I've also used it on like a haloma, interdigital haloma that was kind of breaking down, and it actually helped. So I think stimulating more blood flow to that area helped that heal up quicker. Many indications though.
Great. Thank you very much. And there's no other questions. So we'll just thank you very much.
Thanks,
We
Donna.
appreciate everything. That was wonderful, and enjoy the rest of the day and the conference.
Yep. Take care, everyone.
Bye.
Have fun.